Hi everyone, my name is Kyle Keegan, and today I'll be presenting my individually contracted honors thesis with Dr. Mark Pachucki, Dr. Susan Shaw, and Dr. Melissa Thayer. The title of my thesis is Variation of Massachusetts Residents' Knowledge, Perceptions, and Usage of Urgent Care Centers and Hospital Emergency Departments by Demographic Characteristics. Today I'll be going over an introduction, literature review, methods, findings, limitations, and conclusion. Urgent care centers are typically defined as freestanding physician's office with extended hours, provide care primarily on a walk-in basis, provide x-ray and laboratory services, and have an expanded treatment range that address low to mid-acuity injuries and illnesses. These sites typically have reduced costs and wait times compared to hospital emergency departments and typically have increased care capabilities compared to primary care providers. These sites do not include retail clinics, which are typically found within CVS's or Walgreens. Overcrowding is an important issue to understand for this thesis, as overcrowding of hospital emergency departments can delay treatment, lead to poorer patient outcomes, increase pressure on healthcare providers, and many other issues. This can be a result of multiple systematic issues affecting hospital, but low acuity patients' overuse plays a factor. These issues can also exacerbate healthcare inequalities. Systematic sources of healthcare inequalities are based upon structural inequalities and social determinants of health, which can affect individuals adversely. Structural inequalities can refer to systematic disadvantages of one social group that are based upon personal, interpersonal, institutional, and systematic drivers. And social determinants of health can be categorized into many categories, but we will be focused on education, income, health systems and services, and the social environment. The most important findings from urgent care center research is that 13.4% of emergency department visits could take place at urgent care centers for overlapping diagnoses, and that there was a 6% overlap in 20 of the most common diagnoses between urgent care centers and hospital emergency departments. These overlaps could reduce wait times at hospital emergency departments if urgent care centers are utilized properly. Proximity to hospital emergency departments to affiliated urgent care centers was associated with a relative decrease in the likelihood of visiting the ED for low acuity conditions. There was a reduction in costs at $228 to $414 less at urgent care centers versus hospital emergency departments, or even up to 10 times less costs at urgent care centers compared to hospital emergency departments. Care at urgent care centers is equivalent in quality to hospital emergency departments, and there's also a finding that higher proportions of Black individuals and patients over the age of 85 use urgent care centers to a higher degree compared to other sites. This could reduce race-related health disparities, but could also increase health inequalities as a result of some urgent care centers and similar sites locating in areas of higher income and private insurance. It is important to understand factors that impact care seeking as this study looks to understand the perceptions of urgent care centers and usage of such sites compared to hospital emergency departments. Some of the factors that impact care seeking include health seeking based on patients' own health concerns and their associated anxiety, expecting investigations such as x-rays and lab testing, convenience, lack of confidence in other care professionals, advice from others, population level factors that include demographic characteristics, health infrastructure factors, risk minimization, need for speed, and frustration. The electronic survey that was used for this thesis was approved by the UMass IRB on November 5, 2020, and pilot tested with 5 individuals to test for adult comprehension and interface issues. The survey was distributed from January 28th to February 3rd of 2021, and Massachusetts was used as the location of data collection as a result of high levels of education, income, and healthcare. A total of 2,892 surveys were received, and data cleaning resulted in 2,050 kept for analysis. The responses that were removed were below a progress rate of 50%, those that selected disagree with the consent form, and any respondents that did not have any information inputted. The initial target of Facebook groups in Massachusetts was 661, but as a result of Facebook restricting the amount of Facebook groups I was allowed to enter, 361 were finally requested into, and 190 were able to be posted in, yielding a success rate of 52.63%. The heat map on the right shows the respondent locations for the survey. After initial cleaning, demographic factors were translated into numeric values, and 36 close-ended questions that consisted of scenarios and care capability questions for urgent care centers and hospital emergency departments were analyzed in order to create a knowledge scale. Respondents that had below a knowledge-based score of less than 0.39 were changed to a null value. Open-ended questions were coded using keywords and phrases. An example of coding for yes to urgent care centers being helpful was that when I can't see my doctor, I know I can still get day of care for non-life-threatening issues without clogging up the emergency department. This was coded to allows access to care when PCP unavailable, reduce wait time, manage non-urgent issues, and reduce low acuity patients at ED. The knowledge-based scale resulted in a mean of 0.78, a standard deviation of 0.05, and a range of 0.39 to 0.92. The findings based on knowledge-based scores by sample characteristics resulted in highest knowledge-based groups and lowest knowledge-based groups. The highest knowledge bases resulted from having a doctorate, an income of $150,000 to $200,000, being female for both gender and sex, being white, and from the counties of Hampshire and Hamden. The lowest knowledge base resulted from having an education of high school graduate, GED or less, an income less than $10,000, not being female, being non-white, and from the counties Barnstable and Franklin. Age had an even distribution without much difference by categorical age group. 5 models of linear regressions were performed, but Model 5 is the most important for the study. Model 5 included the demographic characteristics, the perception that urgent care centers are helpful, and the care results of urgent care centers and hospital emergency departments. The R-square value resulted in 0.091, which is very low, but at the same time does show a positive association between these factors and increasing knowledge base. The takeaways of this model is that as levels of income and education increased, knowledge base increased as well, while being statistically significant. Increased age resulted in a slight decrease in knowledge base, and the perception of urgent care centers as helpful increased knowledge base to a large degree. All these factors were statistically significant that are included in these takeaways. This shows that demographic characteristics may impact knowledge base as seen by the association. The question, "Are urgent care centers helpful?" was asked to see if respondents perceived urgent care centers as helpful or not. Negative views were a result of mostly personal experiences, but positive views showed similar results as prior literature. These positive views included reducing low acuity patients at emergency departments, reduced wait time and costs, increased access to care, quality care, and manage non-urgent issues, which is those low acuity issues that are seen resulting in overcrowding at hospital emergency departments. The question, "Do you believe urgent care centers are confusing?" was asked, and most respondents selected that they did not think urgent care centers were that confusing. The responses to yes were coded in order to understand the perceptions behind urgent care centers being confusing. Most of these responses resulted from individual experience, so poor experience, trust issues, and a lot of the responses also came as a result of confusion as a result of reduced knowledge base of urgent care centers. This included how to best use them, assurance issues, and care capabilities of urgent care centers. There were some systematic issues that came up, like a lack of follow-up of continued care or inconsistency across sites in private versus affiliated urgent care centers. The final perception-based question was, "Do you believe you will use urgent care centers more in the future?" Most people said yes, they would. A similar amount said maybe, and the least amount said no, they would not. It was important to understand the responses as a result of no to see what the issues of urgent care centers were. However, most people believed they used the healthcare system properly, so they didn't need them, or they used them as needed, or used their PCP or other providers more often. Other people noted that the system provides enough for respondents' needs, and other personal experience issues came up, such as negative experience or lack of trust. Other important findings as a result of the study were based upon wait time and usage history. The mean wait time at an urgent care center was within 30 minutes, and at a hospital emergency department between 30 minutes and 1 hour, showing that urgent care centers had reduced wait times compared to hospital emergency departments. Usage history showed that urgent care usage was increased over time and at higher rates. This shows that the higher rates of usage at urgent care centers compared to hospital emergency departments was important, as it shows that urgent care centers are in fact utilized in the healthcare system and an important piece of it. Some limitations during the study was that user bias resulted from using Facebook as the site of survey distribution. This resulted in survey responses that were predominantly white, well-educated, high middle to upper class women. Also, further analysis is needed on the study itself, since not all the survey questions were analyzed and further multivariate regressions could not be performed, which could show further associations between demographic characteristics and knowledge base, or other perceptions of urgent care centers and hospital emergency departments. The overall conclusions of the study include associations between increased income and increased knowledge base, increased age and decreased knowledge base, and the perception of urgent care centers increasing the knowledge base the most with statistical significance. UCC Helpful showed the importance of UCCs in reducing healthcare inequalities because of the increased access to care, reduced wait time and costs, care capability between PCPs and HEDs. Negative perceptions of urgent care centers were predominantly based upon individual factors, but did show that increasing consistency across sites and further integration into the healthcare network could help promote urgent care centers in the healthcare network. Urgent care centers have reduced wait times compared to hospital emergency departments as well. I would like to thank Dr. Mark Pachucki, Dr. Melissa Thayer, and Dr. Susan Shaw for the help in this thesis, as well as the Commonwealth Honors College and the Sociology